Imagine a medical intervention that costs, just pennies.
Right.
It doesn't require a doctor to administer. You can literally buy the primary ingredient at your local grocery store, and yet it has the power to cut infant mortality from certain infections entirely in half.
It's honestly incredible when you look at the data.
Yeah, it really is. So today, we are talking about how rubbing common sunflower seed oil on premature babies is actively saving lives.
We are. And we're also going to explore misfolded proteins that literally turn human brains into sponges.
Oh, wow. Yeah. And we are going to unpack the uncomfortable reality of why the global fight against infectious disease is often entirely dependent on your zip code.
It is a staggering spectrum.
Right. Yeah.
I mean, we are moving from the most ancient parasitic worms to these novel microscopic protein errors.
Right.
All while trying to understand the massive invisible systems that allow these pathogens to thrive in the first place.
And to understand those systems, we are using a very specific framework today. For those of you reading along, this deep dive is a companion to Chapter 8.11 of the Oxford Textbook of Global Public Health.
Which covers infectious diseases and prions.
Exactly. We are here to help you synthesize this material, strengthen your clinical reasoning, and, look at the underlying mechanisms. So think of your body, and by extension, our entire global population as a sprawling, intricately connected, fortified city.
I love that metaphor.
Right. You have outer walls, internal supply lines, and elite city guards. But outside the gates are these opportunistic invaders constantly probing the mortar, looking for an unguarded gate or a contaminated water well.
Right, and in public health, our interventions are essentially the structural engineering of this city.
So how does that structural engineering actually work in practice?
Well, it's the core conceptual framework of public health. When we analyze an infectious disease, we don't just look at the bug itself.
Oh, really? We look broader than that.
We have to. We move from the macro to the micro. We start with what we call distal determinants.
Distal determinants. Okay, break that down for us.
Yeah, so this is the overarching socio-political environment. We're talking poverty, systemic marginalization, lack of education.
I see. So the big picture societal issues.
Exactly. And these distal factors create what we call intermediate risk factors.
Like what, for example?
Think of severe household crowding or indoor air pollution from cooking fires or a lack of municipal sanitation.
Oh, got it. So those risk factors are what physically expose the population to the proximal causes.
You got it.
So the proximal causes are the actual biological agents, like the pneumococcus bacteria, the dengue virus, or even the underlying malnutrition that weakens the host's immune system to the point of failure.
Exactly, that chain of events. And finally, that proximal exposure leads to the system impact.
Which is what we actually measure in the clinics, right?
Right? The measurable morbidity, mortality, and the overwhelming of local healthcare infrastructure.
So if you want to actually solve a global public health crisis, treating the proximal cause with an antibiotic is just like fighting a fire.
It's exactly like fighting a fire. To stop the fires from starting, you have to look at the poverty, the crowding, and the policy failures that allowed the invasion to breach the city walls in the first place.
I want to look at the raw numbers of this siege because the historical context here is critical.
It really is.
Like in high-income industrialized nations, the epidemiological transition is largely complete. We die of chronic conditions now, heart disease, cancer, diabetes.
Right, the shift away from infectious diseases.
Yeah, but to see how far we've come with infectious disease, just look at the United States in the 20th century. In the year 1900, infectious disease mortality in the U.S. was 797 deaths per 100,000 people.
That's massive.
And by 1980, that number had plummeted to just 36 per 100,000.
It represents one of the most monumental shifts in human history, really. And we saw echoes of this success globally in the late 20th and early 21st centuries.
It did, yeah.
The total number of child deaths under the age of 5 was cut in half between 1960 and 1990. Then, from 1990 to 2011, under 5 mortality dropped again.
From nearly 12 million annual deaths down to about 6.9 million, right?
Exactly.
That sounds like an unmitigated victory. But the textbook points out a fascinating and really tragic paradox in this data.
Right, the neonatal paradox.
Yeah. As the absolute number of kids dying drops, the proportion of those deaths happening in the neonatal period, which is, the first 28 days of life, has actually surged.
It has.
In 35 specific countdown countries, neonatal deaths now account for more than 40% of all child deaths. Why is the danger suddenly concentrating in the first month of life?
Because the nature of the required intervention completely changes.
How do I mean?
Well, the public health victories that drove down mortality in older infants and toddlers relied on interventions that are relatively straightforward to scale and deliver.
Like vaccines.
Exactly. Think of broad immunization campaigns, or distributing oral rehydration packets, or, handing out insecticide-treated mosquito nets for malaria.
Right, things you can hold in your hand.
Right. These are discrete, tangible products.
Well,
You can load them onto a truck, set up a clinic in a village square, and protect hundreds of children in a single afternoon.
you don't need a hospital to hand out a mosquito net.
Exactly. But keeping a 2-day-old premature baby alive is a totally different logistical universe.
Oh, I see.
Precisely. Saving a vulnerable neonate requires a continuously functioning, complex health system.
So it's not just a product, it's an entire infrastructure.
Exactly. It requires a skilled birth attendant who can recognize fetal distress. It requires a sterile delivery environment to prevent immediate sepsis.
Right.
It requires electricity for temperature control in incubators and oxygen supply lines for respiratory support.
Wow, yeah.
Yeah.
So as we successfully eradicate the easier causes of death in older children using targeted campaigns, the mortality that remains stubbornly behind is concentrated in that highly vulnerable neonatal window.
Right, where you need robust, systemic structural engineering, not just a one-off product delivery.
Which explains the staggering geographic disparity the text highlights. 99% of all neonatal deaths occur in low and middle income countries.
It's a sobering statistic.
It really is. This is no longer a biological mystery. It is a profound structural failure.
Yes.
The neonatal mortality rate, or NMR, in high-income countries is about 4 deaths per 1,000 live births. In the poorest countries carrying this burden, it is 33 per 1,000 live births.
And the heavy hitters causing these deaths are pneumonia, diarrhea, and neonatal disorders.
So let's look at the primary breach point for these pathogens. We're talking about the respiratory system.
The biggest vulnerability in the walls.
Right. Pneumonia is the single largest infectious killer of children globally, responsible for roughly 18% of all under 5 deaths. That's about 1.4 million kids every year. Why are the lungs so uniquely vulnerable?
Well, think about the anatomy. The respiratory tract is essentially an open, continuous highway from the outside environment straight deep into your core anatomy.
Just a direct pipeline.
Exactly. We classify these acute respiratory infections, or ARIs, based on geography.
Geography within the body.
Right. Upper ARIs involve the nose, throat, and ears, your common cold, pharyngitis, or otitis media. They are incredibly common, but rarely fatal.
Okay, so the upper stuff is usually fine.
Generally, yes. The real danger lies in the lower ARIs, involving the bronchioles and the alveoli, specifically bronchiolitis and pneumonia.
And the mortality there is highly concentrated, isn't it?
Very much so. 75% of all childhood pneumonia cases occur in just 15 countries.
Wow. Now, I know Streptococcus pneumonia is the usual suspect when we talk about the etiology of lower respiratory infection.
It's the classic culprit.
But what I don't get is how it manages to bypass the mucosal defenses in a child when that exact same bacteria often lives completely harmlessly in the upper respiratory tract of healthy adults.
That's a really great question of pathophysiology. Streptococcus pneumonia, or pneumococcus, is indeed the undisputed king of bacterial pneumonia, causing up to half of all cases.
So why does it hit kids so hard?
In an adult, a mature immune system and an intact mucosal barrier usually keep it colonizing the nasopharynx without causing disease.
Okay.
But children have naive immune systems. And furthermore, we have to look at the viral vanguard.
The viral vanguard, like an initial attack.
Exactly. Viruses like respiratory syncytial virus, or RSV, influenza, and adenoviruses are incredibly adept at infecting children.
Oh, I see.
These viruses sweep through the respiratory tract, killing the epithelial cells and stripping away the protective mucus layer.
So they basically destroy the outer wall.
They literally pave the way, creating raw, unprotected tissue that allows the colonizing pneumococcus to drop down into the lungs and establish a massive secondary bacterial infection.
Wow. So the virus breaches the outer gate and the bacteria flood the city.
Exactly.
Now, diagnosing that bacterial flood in a high-income hospital is straightforward. You order a chest x-ray to look for consolidations, you draw blood cultures, you hook up a pulse oximeter.
Right, you have all the tools.
But the World Health Organization's diagnostic algorithm for resource-poor settings is entirely different. It relies on a community health worker with nothing but a timer.
The WHO algorithm is brutally elegant in its simplicity, really.
How does it work?
It defines non-severe pneumonia strictly based on respiratory rate thresholds. If you have an infant aged 2 to 11 months and they're breathing 50 breaths per minute or more, that child has pneumonia.
Just based on the breathing rate.
Just the rate.
Mm.
For a child aged 12 to 59 months, the cutoff drops to 40 breaths per minute or more.
And what about severe pneumonia?
If you add lower chest wall indrawing, where the ribs violently suck inward during inspiration because the lungs are so stiff with infection, that classifies as severe pneumonia.
But let's push back on this from a clinical perspective.
Sure.
If we rely purely on counting breaths, aren't we inevitably overdiagnosing? I mean, a child with a viral asthma exacerbation or just a really bad fever from a common cold is going to be breathing fast.
Yes, they absolutely will be.
If we label all of them as having bacterial pneumonia, we are going to hand out massive amounts of unnecessary antibiotics. Isn't this directly driving the global crisis of antimicrobial resistance?
You are identifying the central tension in global public health diagnostics right there.
It seems like a huge risk.
It is. The WHO algorithm fundamentally lacks specificity. It will overdiagnose viral illnesses as bacterial pneumonia.
Then why do we use it?
Because we have to differentiate between the goals of a diagnostic tool in a resource-rich setting versus a high-mortality, resource-poor setting.
Oh, I see. So the stakes are different.
Entirely different. The public health reasoning here prioritizes sensitivity over specificity.
Meaning the priority is to cast the widest possible net to ensure you catch every single true case, even if you catch some dolphins in your tuna net.
Exactly. In a remote rural village, if a health worker misses a true case of bacterial pneumonia because they were holding out for an X-ray or a blood culture that will never arrive,
then the child dies.
that child will die within 48 hours. The calculus of public health dictates that overprescribing antibiotics in this specific context is a calculated, acceptable risk to ensure no actual bacterial pneumonia slips through undetected.
It's choosing the lesser of two evils to put out the immediate fire.
Exactly.
And the text notes a major paradigm shift regarding who is fighting these fires. Historically, if a child had severe pneumonia with chest indrawing, the mandate was immediate hospital admission for intravenous antibiotics.
Right.
But recent trials, notably in Pakistan, have shown incredible success using community health workers, or CHWs, to treat severe pneumonia right in the village using oral amoxicillin.
This is a profound shift in health service delivery.
Why is it so important?
The reality is that for millions of families, the nearest hospital is a 3-day walk, or it requires bus fare they just don't have.
So a referral is basically a death sentence.
Often, yes. Mandating hospital referral often meant the child received no treatment at all. The trials demonstrated that CHWs could be trained to accurately diagnose severe pneumonia and administer oral amoxicillin.
And oral is enough. You don't need an IV.
Because amoxicillin has excellent oral bioavailability, meaning it gets absorbed into the bloodstream from the gut very efficiently, it can be highly effective without needing an IV.
Wow.
By bringing the intervention directly to the patient's home, treatment delay is eliminated and survival rates improve dramatically.
So we've talked about how to fight the infection once it's there, but I want to shift to upstream engineering, preventing the breach entirely.
Essential.
Vaccines are obviously our primary shield here. The Haemophilus influenza type B, or Hib vaccine, and the pneumococcal conjugate vaccines, the PCVs, have been revolutionary.
They absolutely have.
But the text highlights an environmental risk factor that really shocked me: indoor air pollution.
Oh, yes. It's a massive issue.
Nearly half the global population still relies on solid biomass fuels, wood, crop waste, charcoal for cooking inside their homes.
The impact of indoor biomass smoke on respiratory health cannot be overstated.
How does it actually hurt the lungs?
When a child is constantly inhaling thick, particulate-heavy smoke from a kitchen fire, it directly attacks the microscopic anatomy of their lungs.
The physical structures.
Yes. Your respiratory tract is lined with cilia-tiny, hair-like projections that constantly beat upwards in a coordinated wave.
Right.
This is the mucociliary escalator, and its job is to physically sweep trapped pathogens and debris up and out of the lungs so they could be coughed out or swallowed.
So the smoke essentially paralyzes the cleaning crew.
It does worse than paralyze them. The toxic particulate matter, specifically PM2.5, severely damages and blunts the cilia.
Oh, it destroys them.
And it also impairs the local immune cells in the lungs, the alveolar macrophages.
So with a double hit.
Exactly. When the physical sweeping mechanism is broken and the local guards are intoxicated by smoke, any pneumococcus that wanders down the respiratory tract finds a perfectly hospitable, undefended environment to replicate.
Man, So replacing these open fires with clean, ventilated cook stoves is just as vital a structural defense against pneumonia as a vaccine.
It truly is.
Okay, we've seen how the respiratory system is compromised. Let's trace the path of these pathogens as they seek deeper access to the city's infrastructure.
Moving into the bloodstream.
Right. Often, they breach the initial barriers and enter the bloodstream. We are shifting focus now to the most fragile demographic, neonates. We are talking about neonatal sepsis and meningitis, which account for about 0.39 million deaths annually.
To clinically manage neonatal sepsis, we rigorously categorize it by timeline because the timeline tells you exactly where the pathogen came from.
Okay, so time is a clue.
Yes. We differentiate between early onset sepsis, or EOS, and late onset sepsis, LOS.
Let's start with early onset.
Early onset sepsis occurs within the very first few days of life, typically defined as presentation within 48 hours to 6 days after birth.
And where do these bugs come from?
The pathogens responsible for EOS are acquired vertically, meaning they are transmitted from the mother's genital tract before or during the physical process of delivery.
Now, the textbook notes a fascinating geographical divide here. In high-income developed nations, the pathogen we obsess over for early-onset sepsis is Group B streptococcus, or GBS.
Right.
But in developing nations, a major culprit is completely different. It's Klebsiella pneumonia.
And that ideological difference dictates our policy.
How so?
Because the hazard for EOS is present during birth, the intervention must be targeted at the mother and the delivery environment.
Okay, so pre-delivery interventions.
Exactly. In developed nations, we routinely swab pregnant women for GBS late in the third trimester, and if they are positive, we administer intrapartum intravenous antibiotics during labor.
To protect the infant as it passes through the birth canal?
Right. But in developing nations, the focus is heavily placed on the 6 cleans of delivery.
What are the 6 cleans?
Clean hands, clean delivery surface, clean cord-cutting instrument, and so on, to prevent environmental pathogens like Klebsiella from colonizing the infant during birth.
That makes total sense. But then we have the second category. Late onset sepsis.
Yes.
This hits after that initial golden window, often presenting from day 7 onward. Where do these invaders come from?
Late onset sepsis is acquired post-delivery. The infant has left the birth canal and is now interacting with the external environment.
So it's from the world around them.
Exactly. The infection can be community-acquired from the home setting, or tragically, it can be nosocomial, meaning hospital-acquired.
Right, from the clinic itself.
The pathogens shift to environmental bacteria like E. coli, Staphylococcus aureus, and highly resistant gram-negative organisms.
So if a baby gets sick on day 2, we look at the birth process. If a baby gets sick on day 15, we look at who has been touching the baby.
Precisely. Hospitals in resource-limited settings can unfortunately become hotbeds for late-onset sepsis.
Why is that?
Overcrowded neonatal units, severe understaffing leading to compromised hand hygiene between patients, and the forced reuse of disposable medical supplies.
Oh, that's a perfect storm.
It really creates perfect transmission vectors for multi-drug-resistant pathogens to spread from one incubator to the next.
Which brings me back to the hook we started this deep dive with, the incredibly low-tech interventions that provide massive structural defense.
Yes, the chlorhexidine and the oil.
Exactly. The textbook highlights applying a 4% chlorhexidine solution to the infant's umbilical cord stump.
Think about what the umbilical cord is immediately after it's cut.
It's basically an open wound, right?
It is a mass of necrotic tissue containing raw, open blood vessels that lead directly into the infant's systemic circulation.
Wow. It is essentially an open, unguarded gate.
Applying an antiseptic like 4% chlorhexidine acts as a potent chemical barrier.
Just a quick swab.
Right, and it drastically reduces the incidence of omphalitis, which is the infection of the umbilical stump, and blocks pathogens from using those vessels as a highway into the blood.
And then there's the sunflower seed oil. I was blown away by this when I read it.
It's a beautiful intervention.
Rubbing a common cooking oil on the skin of premature infants reduces their risk of infection by roughly 50%. Explain the biology of why this works.
To understand the magic of sunflower oil, you have to understand the anatomy of premature skin.
Okay.
In a full-term baby, or in you and me, the outermost layer of the skin is called the stratum corneum.
Right, the tough outer layer.
It is a robust, microscopic wall of dead, flattened skin cells bound together by specialized lipids. It acts as a waterproof barrier, keeping moisture inside our bodies and keeping bacteria out.
But a premature baby doesn't have that yet.
Exactly. In a premature infant born at, say, 28 weeks, that stratum corneum hasn't formed yet. Their skin is incredibly thin, almost translucent.
So it's not protecting them at all.
It's essentially a leaky roof. Because they lack that lipid barrier, they suffer massive transepidermal water loss. They literally evaporate, and the skin provides a highly porous, undefended entry point for any bacteria resting on its surface.
They have the bricks, but they haven't manufactured the mortar yet.
That is a perfect analogy. The essential fatty acids in sunflower seed oil, specifically linoleic acid, act as artificial mortar.
Oh, so it just fills in the gaps.
When gently massaged into the premature infant skin, the oil is absorbed and physically restores the lipid barrier. It fixes the leaky roof, preventing water loss and creating a physical barricade against the bacteria that cause late-onset sepsis.
That is amazing. It is brilliant, physiologically sound systems engineering using a locally available, dirt-cheap resource.
It really is public health at its finest.
I love when complex public health problems have elegant physiological solutions. Now, let's talk about the absolute worst-case scenario. When sepsis isn't contained and the bacteria cross the blood-brain barrier to infect the lining of the brain and spinal cord, we are talking about bacterial meningitis?
Meningitis is absolutely devastating.
Tell us why.
Well, the skull is a rigid, closed, bony box. When bacteria invade the meninges, the membranes surrounding the brain, the body's immune system responds with massive inflammation.
Which usually involves swelling, right?
Right. White blood cells flood the area, blood vessels become leaky, and tissues swell. But because the skull cannot expand, this inflammatory swelling creates skyrocketing intracranial pressure.
Oh, and the brain has nowhere to go.
Exactly. This pressure crushes the delicate brain tissue, leading to severe neurological damage, profound hearing loss, or death, even if you manage to kill the bacteria with antibiotics.
The textbook highlights a really interesting geographical discrepancy in how we treat this inflammation.
The corticosteroid debate.
Right. In high-income countries, the standard of care for bacterial meningitis, particularly when caused by Haemophilus influenza type B, involves giving potent intravenous corticosteroids right before or alongside the first dose of antibiotics.
The rationale there is to blunt the immune system's violent reaction.
Because the immune system is doing the damage.
Yes. When the antibiotic hits the bacteria, it shatters their cell walls, releasing a massive wave of inflammatory debris into the spinal fluid.
So you need something to calm that down.
Giving a corticosteroid, like dexamethasone, acts as a systemic fire blanket. It suppresses the cytokine storm, reducing the swelling and significantly protecting the patient from severe hearing loss and neurological sequelae.
But here is where context is everything.
Absolutely.
The text specifically points to a Cochrane review showing that giving corticosteroids has no beneficial effect for children suffering from meningitis in low-income countries.
Right.
Why? Is the biology of a child in Malawi different from a child in Massachusetts?
The underlying human biology is identical, of course,
Mm-hmm.
but the systemic and clinical context is entirely different.
In what way?
In low-income countries, due to lack of access to care or reliance on traditional healers first, patients present to the clinic significantly later in the disease course.
Oh, so it's a timing issue.
Precisely. By the time they receive steroids, the massive inflammatory cascade has already been raging for days. The neurological tissue is already necrotic. The damage is done.
So the fire blanket is useless if the house is already burned down.
That's exactly it. Furthermore, children in these settings often have different underlying etiologies.
Like what?
Higher rates of concurrent severe malnutrition or undetected co-infections like malaria or HIV, all of which fundamentally alter how their immune system processes inflammation and responds to immunosuppressive steroids.
It is a cautionary tale for global health policy, really. You cannot blindly export a clinical guideline developed in Boston to a rural hospital in Bangladesh and expect identical results without accounting for the systemic context.
Context is everything in public health.
Okay, we've covered the airborne siege on the lungs and the bloodstream breaches in the neonates. Let's shift our gaze to the gastrointestinal tract, which represents the fourth leading cause of global disability-adjusted life years, or DALYs.
The waterborne assault.
Exactly.
Diarrheal disease remains a massive killer, though it's important to note that global mortality from diarrhea has fallen significantly over the past decades thanks to targeted interventions.
But epidemiologically, there's a very specific danger zone, right?
Yes, the incidence of diarrheal disease peaks sharply between 6 and 11 months of age.
Why is that half-year window so treacherous?
It is the weaning period, representing a profound immunological and environmental transition.
Okay, break that down.
For the first 6 months, if an infant is exclusively breastfed, They are receiving highly sterile nutrition that is packed with maternal antibodies.
Right, the mother's immune system is protecting them.
Specifically, secretory IgA, which coats the infant's gut and actively neutralizes pathogens.
But that changes at 6 months.
It does. Two things happen simultaneously. First, the maternal antibodies acquired during pregnancy are waning, and the child's own active immune system is still naive.
Then the second thing.
Second, the mother begins introducing complementary foods and water.
Oh, and that's where the exposure comes in.
Exactly. In resource-poor settings lacking clean municipal water, these weaning foods, or the water used to mix them, are frequently contaminated with fecal pathogens.
So the child experiences a sudden, massive increase in pathogen exposure exactly when their immunological defenses are at their lowest.
It is a perfect storm.
And these ingested pathogens cause two very distinct clinical syndromes that we need to unpack: non-inflammatory diarrhea and inflammatory diarrhea. Let's start with non-inflammatory.
Non-inflammatory diarrhea primarily targets the small intestine. The classic culprits here are rotavirus, Vibrio cholerae, and enterotoxigenic E. coli or ETEC.
What's their mechanism? Do they destroy the tissue?
No, these pathogens generally do not destroy the tissue of the gut. Instead, they operate via biochemical sabotage.
Biochemical sabotage.
Yes. Cholera, for example, releases a toxin that permanently switches on a cellular messenger called AMP within the intestinal cells.
And what does that messenger do?
It forces the cells to dump massive amounts of chloride ions into the gut lumen, and water violently follows the chloride via osmosis.
Wow, so the body is actively pumping its own water out into the intestines.
Exactly. It results in a massive outpouring of watery fluid, sometimes liters a day.
But no blood.
Because there's no major tissue destruction, there's usually no blood in the stool. But the sheer volume of water and electrolyte loss can drop the patient's blood pressure to 0, causing rapid, fatal hypovolemic shock in a matter of hours.
That's terrifying. Contrast that mechanism with inflammatory diarrhea, which is often called dysentery.
Inflammatory diarrhea targets the large intestine, or the colon.
Different geography entirely.
Right. And the pathogens here are aggressive physical invaders. Bacteria like Shigella, Campylobacter, and parasites like Entamoeba histolytica.
So they don't just mess with the fluid transport.
No, they physically invade the mucosal lining of the colon, kill the host cells, and cause severe inflammation and ulceration.
Which produces a very different clinical picture, I'd imagine.
Very different. Because the colon is physically damaged, the stools are of smaller volume, but are packed with visible blood, mucus, and white blood cells.
That sounds incredibly painful.
It is. This tissue destruction is highly painful, often accompanied by severe abdominal cramps, and a symptom called tenesmus.
Let's define tenesmus for our listeners.
Tenesmus is the distressing, constant feeling of needing to pass stool, accompanied by straining and pain, even when the bowels are completely empty.
Why does that happen?
It happens because the severe inflammation of the rectal mucosa causes the nerves to spasm, sending false signals to the brain that the rectum is full.
Because the mechanisms of these diarrheal diseases are so destructive to the body's energy and fluid reserves, I want to bring up a piece of traditional advice that many of us grew up hearing. Starve a fever, rest the bowel.
Oh, yes. The resting the bowel myth.
Right. If a child has severe diarrhea, the instinct is to stop feeding them to let the stomach settle. Why is that advice actively lethal in a developing nation?
Resting the bowel by withholding food is one of the most dangerous myths in medicine.
Really?
Yeah.
That dangerous?
Yes. Diarrhea creates a severe negative nutritional balance. The child usually has a fever, which drastically increases their baseline metabolic demand and burns through calories.
Okay.
Simultaneously, the infection causes malabsorption, meaning even the food they do eat isn't absorbed properly.
So they're starving even if they eat?
Exactly. If you restrict a child's caloric intake during this crisis, you rapidly accelerate them into a state of severe protein energy malnutrition.
And malnutrition wrecks the immune system.
That severely impairs the immune system, which means the child can't fight off the pathogen. The diarrhea lasts longer, the gut lining takes longer to heal, and the malnutrition deepens. It is a deadly, self-amplifying cycle.
So what's the actual medical mandate?
The medical mandate is continuous feeding, especially continuous breastfeeding, to provide the raw materials needed to repair the gut lining and sustain the immune response.
And to address the fluid loss itself, the greatest public health intervention of the 20th century is oral rehydration solution, or ORS.
Without a doubt.
It seems like just salt and sugar water, but the physiology behind it is Nobel Prize worthy. And the textbook notes that the specific recipe has actually evolved.
It has.
The standard WHO ORS, formulated in the 1970s, used to have quite a high concentration of sodium, 90 millimoles per liter.
It did, and a specific concentration was highly intentional for the era.
Why so much salt?
The original ORS was developed primarily to combat cholera outbreaks. Cholera diarrhea contains massive amounts of sodium, so the replacement fluid needed to match those extreme losses.
But the global epidemiology of diarrhea shifted.
It did. Public health officials realized that globally, the vast majority of childhood diarrhea is non-cholera.
It's mostly viral, right?
Yeah, it's viral rotavirus, or ETEC.
Hmm.
These non-cholera diarrheas involve water loss, but significantly less sodium loss than cholera.
So giving them the high sodium ORS is actually bad.
Here is the physiological problem. ORS works by utilizing a specific protein channel in the gut wall called the sodium-glucose cotransporter, or SGLT1.
Okay, the SGLT1 channel.
This channel acts like a turnstile that only turns if one molecule of sodium and one molecule of glucose enter it together, dragging water along with them into the bloodstream.
Right.
If you give a child with non-cholera diarrhea the old high-sodium ORS, you are forcing more sodium into their blood than they actually lost.
Which risks creating hypernatremia, right?
Yes, dangerously high sodium levels in the blood, which draws water out of the brain cells, potentially causing seizures or neurological damage.
Wow. So the WHO had to re-engineer the recipe to match the modern threat.
They shifted to a low osmolarity ORS. They reduced both the sodium to 75 millimoles and the glucose to 75 millimoles.
So it perfectly matches the physiological reality of non-cholera diarrhea.
Exactly. It maximizes water absorption through the SGLT1 turnstiles without overloading the infant's delicate system with excess salt.
And we also add a specific trace mineral to the regimen now. Zinc. 10 to 20 milligrams a day for 2 weeks. I was surprised by how profound an effect this single mineral has.
Zinc is a biological game changer for enteric infections.
How does it work?
During a severe bout of diarrhea, the enterocytes, which are the specialized absorptive cells that line the inside of the intestines, are damaged or destroyed.
So the lining is compromised.
Right. Zinc is a critical cofactor for cellular regeneration. Providing supplemental zinc accelerates the regeneration of these enterocytes, repairing the physical mucosal barrier.
And it boosts the immune response too, doesn't it?
It does. It boosts the local immune response in the gut. Clinical trials show that zinc not only reduces the duration and severity of the current diarrheal episode, but it actively protects the child from catching another episode of diarrhea for the next 2 to 3 months.
It is literal structural engineering, rebuilding the physical wall of the gut while the battle is still happening.
Absolutely.
Well, we've covered the respiratory and gastrointestinal systems, but not all invaders breach the walls directly through the air or water.
No, some are much sneakier.
Right. Some spread systemically, hiding within the body's own infrastructure, or they use biological Trojan horses vectors to bypass our outer defenses entirely. Let's move to Section 5, looking at systemic and vector-borne threats, specifically focusing on typhoid fever and dengue.
Let's start with typhoid fever, which is caused by the bacterium Salmonella enterica cerovar typhi.
It is classified as an enteric fever, right?
Yes. The entry point is the gastrointestinal tract. You ingest the bacteria through food or water contaminated with the feces of an infected person.
But unlike the cholera or rotavirus we just talked about, typhoid doesn't stay in the gut lumen to cause massive diarrhea. It's much more insidious.
It is a systemic infiltrator.
Yeah.
When Salmonella typhi reaches the small intestine, it actively invades the mucosal wall and is taken up by the local immune tissue, the Peyer's patches.
And then what?
From there, it hitches a ride inside our own immune cells, specifically the macrophages, and travels through the lymphatic system into the bloodstream.
So it hides inside the very cells meant to destroy it.
Exactly. It specifically seeks out and sequesters itself within the reticuloendothelial system.
Let's unpack that term, the reticuloendothelial system. We're talking about the network of specialized immune cells, primarily macrophages, that are permanently parked in highly vascular organs to filter the blood.
Exactly. The liver, the spleen, the bone marrow, and the lymph nodes.
So it just sets up camp there.
Salmonella typhi sets up camp inside these organs, multiplying quietly, and then begins seeding the bloodstream in recurrent, massive waves of bacteremia.
Which creates a very specific, prolonged clinical picture that is entirely different from acute dysentery.
The hallmark of typhoid is a prolonged stepwise fever that gets progressively higher over the first week, often accompanied by a severe headache, general malaise, and a dry cough.
But clinically, you might observe a fascinating physiological anomaly, pulse temperature dissociation.
Sometimes called a Faggot sign.
This is a great clinical pearl. Normally, human physiology dictates that for every 1 degree Celsius your body temperature rises during a fever, your heart rate should increase by about 10 beats per minute. It's a standard compensatory mechanism.
Right. But in typhoid, a patient might be burning up with a fever of 40 degrees Celsius, 104 degrees Fahrenheit, yet their heart rate is sitting calmly at 80 beats per minute.
That is so wild. Why does it do that?
The exact mechanism is debated, but it's believed that the bacterial endotoxins either directly depress the heart's natural pacemaker, the sinoatrial node, or cause localized stimulation of the vagus nerve in the inflamed gut.
Which artificially slows the heart rate despite the raging fever.
Exactly.
If typhoid isn't recognized and treated, the progression into the 3rd week is terrifying. The bacteria that initially invaded the Peyer's patches in the small intestine cause those immune tissues to undergo massive hyperplasia.
They swell up and become highly inflamed. Eventually, the tissue simply dies and undergoes necrosis.
Which leads to the most feared complication, intestinal perforation.
The inflamed gut wall physically bursts open, spilling the bacteria-laden contents of the intestines directly into the sterile abdominal cavity, causing massive peritonitis and carrying a very high mortality rate.
And how do we treat it now? Historically, we could reliably treat typhoid with basic antibiotics like ampicillin or chloramphenicol, and later shifted to fluoroquinolones like ciprofloxacin.
But we are now facing a global crisis of multi-drug-resistant, or MDR, and even extensively drug-resistant strains of typhoid that laugh at these conventional drugs.
So what are clinicians forced to use?
Clinicians are frequently forced to rely on azithromycin or expensive 3rd-generation cephalosporins, which are often out of reach in the poorest settings.
While we do have vaccines, like the newer Vi conjugate vaccine, the ultimate public health fix for typhoid isn't pharmacological, is it?
No, it's infrastructural. It's watch water, sanitation, and hygiene.
Right. If you build sewage systems that physically separate human feces from the municipal drinking water, typhoid essentially disappears. But dengue fever. Dengue represents a completely different paradigm. You can have perfect municipal plumbing, but if you have a thriving urban center, you are at risk.
Dengue is a viral infection transmitted by the bite of infected Aedes aegypti and Aedes albopictus mosquitoes.
It's spreading incredibly fast.
It is the most rapidly spreading mosquito-borne viral disease in the world, causing an estimated 50 to 100 million symptomatic illnesses annually.
And these aren't the same mosquitoes that carry malaria, right?
No. Unlike the malaria mosquito, which prefers rural natural water bodies, the Aedes mosquito is perfectly adapted to human urbanization.
They like cities.
They love to breed in tiny artificial pools of stagnant, water-discarded rubber tires, plastic takeout containers, blocked roof gutters, or open water storage jars in dense slum environments.
And dengue presents a really crucial concept for our listeners to master when thinking about epidemiology, the fundamental difference between hazard and risk.
This distinction is vital.
Okay, lay it out for us.
The hazard is the objective presence of the dengue virus and the Aedes mosquito in your physical environment. If you live in a tropical urban center, the hazard is universally high.
But the risk?
The statistical probability of you developing severe, life-threatening disease is not evenly distributed.
Because dengue isn't just one virus.
Exactly. Dengue is not a single virus. It exists as 4 distinct but closely related serotypes: Den 1, Den 2, Den 3, and Den 4.
They are essentially 4 different flavors of the virus.
Precisely. If you are bitten by a mosquito carrying Den N1, you will likely develop classic dengue fever.
Which looks like what?
This involves a sudden high fever, a severe headache, pain behind the eyes, and excruciating joint and muscle pain, which is why it earned the moniker breakbone fever.
Sounds awful.
It is. You might develop a rash, but after a miserable week, your immune system clears the virus, and you are left with robust, lifelong immunity to the Den 1 serotype.
Okay, so that's standard viral immunology. But what I find to be one of the most bizarre and terrifying paradoxes in all of immunology is what happens if you get bitten a year later by a mosquito carrying a different flavor, say DEN2.
Right.
Your own immune system actually makes the second infection drastically worse. Unpack the mechanism behind antibody-dependent enhancement for us.
Antibody-dependent enhancement, or ADE, is a biological nightmare.
How does it work?
When that DEN2 virus enters your bloodstream, your immune system's memory B cells immediately recognize the structural similarities to the dengue virus you fought last year.
They think it's DN1 again.
Exactly. They rapidly pump out the antibodies they originally designed to fight DN1.
But they don't quite fit.
Right. These antibodies bind to the new DN2 virus particles. But because the DN2 serotype has slightly different surface proteins, the DN1 antibodies can't lock on tightly enough to neutralize or destroy the virus.
They grab it, but they can't kill it.
Worse than that. By binding to the virus, these non-neutralizing antibodies inadvertently act as a Trojan horse.
A Trojan horse?
Macrophages, our frontline immune cells, have specialized receptors on their surface, called Fc receptors, which are designed to engulf and destroy anything tagged with an antibody.
Oh, I see where this is going.
The macrophage sees the antibody-tagged DNN2 virus, pulls it inside to destroy it, but because the virus isn't neutralized, it survives.
The DN1 antibody literally hands the live DN2 virus the key to enter the macrophage.
Exactly. The virus then hijacks the macrophage's internal machinery to replicate massively.
So it's replicating inside the very cell meant to eat it.
Yes. This explosion of viral replication within your immune cells triggers a massive, uncontrolled release of inflammatory cytokines.
It's a cytokine storm.
Exactly. This cytokine storm severely damages the endothelial cells lining your blood vessels, leading to profound capillary permeability.
The vessels start leaking?
Plasma, the liquid portion of your blood, rapidly leaks out of the vessels and into your chest and abdominal cavities. Your blood pressure plummets, cutting off oxygen to your vital organs. This is dengue hemorrhagic fever, leading to dengue shock syndrome. The secondary infection with a different serotype skyrockets your risk of severe, life-threatening disease precisely because you had prior immunity to a different strain.
The elite guards meant to protect the city actually escort the invaders straight into the central citadel.
It's a devastating paradox.
This immunological quirk makes creating a dengue vaccine notoriously complex.
Incredibly complex.
I mean, if a pharmaceutical company creates a vaccine that only provides strong immunity against 3 of the serotypes, it could potentially act like a primary infection for the 4th.
Yes.
If that vaccinated person encounters the 4th serotype in the wild, the vaccine could theoretically set them up for antibody-dependent enhancement and severe hemorrhagic fever.
Which is why you need a tetravalent vaccine that provides robust, perfectly balanced immunity to all 4 serotypes simultaneously, which has proven phenomenally difficult to achieve.
So while we continue to refine vaccine technology, the primary structural defense against dengue returns to rigorous vector control.
It has to. It means organizing communities to empty out stagnant water pots, applying larvicides to larger water storage tanks, and utilizing insect repellent.
Especially during the early morning and late afternoon hours when the Aedes mosquito is actively feeding.
Exactly.
Well, we are rounding the corner into our final section, and we are looking at the extreme ends of the infectious spectrum: parasitic infections and prions.
Moving from neglected ancient worms to novel, bizarre proteins.
Let's start with the helminths.
The global burden of helminths is staggering. We are specifically talking about geohelminths, soil-transmitted nematodes.
Which ones are the main players?
The main players are the roundworm Ascarius lumbricoides, the whipworm Trichuris trichiris, and the hookworms.
Mercator americanus and Ancylostoma duodenale.
Collectively, these parasites infect well over 1 billion people globally.
Over 1 billion. In certain endemic regions, it is statistically more common to be infected with a parasite than to be parasite-free.
It is a ubiquitous burden. And while these worms rarely cause acute dramatic death, like cholera or meningitis, they are engines of profound chronic morbidity that traps entire populations in poverty.
Take the hookworm, for example.
Right. The microscopic fleriform larvae live in contaminated soil. When a child walks barefoot, the larvae physically penetrate the intact skin of their foot.
They just drill right through the skin.
They do. They travel through the bloodstream to the lungs, break out into the alveoli, crawl up the trachea to be coughed up and swallowed, finally reaching their destination in the small intestine.
What a journey. And what do they do there?
There, they bite into the intestinal mucosa and literally drink the host's blood. Chronic hookworm infection is a leading cause of severe iron deficiency anemia in developing nations.
And the roundworms and whipworms take a different approach. They compete for the host's actual food.
Yes, a severe roundworm infection can physically block the intestines, but more commonly, it continuously steals the child's calories and micronutrients.
Which leads to all sorts of developmental issues.
It leads to protein energy malnutrition, physical stunting, and significantly measurable cognitive and developmental delays.
So how do you structurally engineer a defense against 1 billion worms living in the soil?
The textbook emphasizes mass drug administration, or MDA, utilizing highly effective single-dose oral anthelminthic drugs like albendazole or mebendazole.
But the brilliance of MDA isn't just the drug, it's the delivery mechanism.
It's all about how you deliver it.
Why do public health programs target these deworming campaigns primarily in schools rather than running them through medical clinics?
Because of pure systems thinking. If you want to deworm a massive population of children, relying on individual families to recognize chronic, low-grade symptoms and spend a day walking to a clinic is deeply inefficient.
It just wouldn't happen on a large enough scale.
Exactly. Schools offer an existing, sustained infrastructure. You have a captive audience of the exact demographic most vulnerable to the morbidity of helminths.
And you have teachers?
You have an existing workforce, the teachers, who can be easily trained to safely dispense a chewable pill twice a year without needing a medical license. You are treating the population where they already gather.
That is the logistical brilliance. But the epidemiological brilliance is the herd effect of mass deworming.
The herd effect is crucial here. Soil-transmitted helminths reproduce by shedding millions of microscopic eggs in the host's feces, which contaminate the local soil and infect the next child.
Right.
If you go into a school and administer albendazole to 80% of the children, you instantly kill the adult worms in their guts. The overall volume of worm eggs being shed into the community's environment plummets.
So even the kids who didn't take the pill benefit.
Landmark public health studies in Kenya demonstrated that when you run a school-based MDA program, even the untreated children in the surrounding community, or the younger siblings at home, see a significant drop in infection rates.
Because the overall environmental transmission hazard has been drastically reduced.
Treating the majority protects the entirety.
That concept that individual medical treatment acts as a population-level environmental intervention is the very essence of public health.
It perfectly illustrates the fortified city metaphor.
Okay, we have moved from worms you can see with the naked eye to a pathogen so small, so fundamentally bizarre that it challenged the central dogma of biology.
Let's pivot to prions.
For decades, the central dogma of molecular biology was strict. Genetic information flows from DNA to RNA to protein.
Right. Therefore, for an agent to be infectious and replicate, it must possess nucleic acids, DNA, or RNA. Bacteria, viruses, fungi, parasites, they all follow this rule.
But prions are a complete terrifying departure.
A prion does not have DNA, does not have RNA. It is simply a protein.
Specifically, it is a misfolded variant of a normal, healthy cellular protein naturally found in the membranes of our brain cells, known as PRPC.
And the misfolded infectious version is designated as PRPSC.
It's just a misfolded shape. How does a shape replicate itself without genetic code?
It acts as a template. When an infectious, misfolded PRPSC prion gains access to your brain tissue and comes into physical contact with your normal, healthy prion proteins, it forces the healthy protein to undergo a conformational change.
It literally bends the normal protein out of shape.
It physically bends the healthy protein into the misfolded shape. That newly misfolded protein then bumps into another healthy protein and misfolds it. It triggers an unstoppable cascading chain reaction.
Wow.
These misfolded proteins are highly resistant to being broken down by the body's natural cellular recycling systems. They aggregate together, forming dense amyloid plaques that clog up and eventually kill the neurons.
Turning the brain into a sponge.
Under a microscope,
Yeah.
the dead brain tissue is full of microscopic holes. It literally turns the brain into a sponge. This is why these diseases are classified as transmissible spongiform encephalopathies, or TSCs. They're universally fatal, and there is absolutely no cure.
The most infamous of these is variant Creutzfeldt-Jakob disease, or VCJD, which was the human manifestation of the mad cow disease outbreak in the United Kingdom in the 1980s and 90s.
It's important to contrast classic sporadic CJD with variant CJD.
How are they different?
Classic CJD is an incredibly rare, spontaneously occurring disease that typically strikes the elderly, with a median age of onset around 68 years. It usually presents as rapidly progressive dementia, memory loss, and physical incoordination, leading to death within a few months.
But variant CJD, which emerged during the UK outbreak, presented completely differently.
The patients were shockingly young.
Right.
Median age was just 27 years old.
27.
Yes. And the onset wasn't typical dementia. It started with prominent psychiatric and behavioral symptoms, severe depression, withdrawal, anxiety, often accompanied by painful sensory symptoms like dysesthesia, where normal touch feels burning or painful.
And the severe neurological signs and dementia were delayed until later in the disease course?
Exactly.
And the textbook notes a very specific diagnostic clue you can see on neuroimaging for VCJD.
Yes. If you perform an MRI on a patient with variant CJD, you frequently observe what is called the pulvinar sign.
What does it look like?
This is a bright, bilaterally symmetric, abnormal signal in the pulvinar nuclei, which are located in the posterior thalami of the brain.
Why there?
The thalamus acts as the brain's primary sensory relay station, which helps explain those early painful sensory symptoms these young patients experienced. The prions were heavily aggregating and destroying the sensory relay.
But the truly terrifying part of VCJD is not just the pathology. It is how it entered the human population in the first place.
The history of the UK BSE bovine spongiform encephalopathy outbreak is a profound lesson in how our industrial food and agricultural systems directly dictate human epidemiology.
The BSE outbreak in UK cattle was entirely man-made, right?
It was driven by a policy change regarding how livestock carcasses were rendered.
Explain that rendering process.
To create cheap, protein-rich animal feed, agricultural rendering plants would take the leftover carcasses of sheep and cattle, including the brains and spinal cords, grind them up, heat them, extract the fat, and feed the remaining protein meal back to dairy cows.
Cows, which are natural herbivores, were being forced into industrial cannibalism.
Exactly.
But rendering plants have been doing this for a long time. Why did the outbreak happen specifically in the 1980s?
Because of a change in the manufacturing process. The rendering plants shifted away from using harsh hydrocarbon solvents to extract the fat and lowered the temperatures of the rendering process to save money and improve the nutritional quality of the feed.
And prions are tough.
Prions are incredibly resilient. They survive boiling, radiation, and formaldehyde. The new, milder rendering process was no longer destroying the prions that were naturally present in scrapie-infected sheep or sporadically infected cattle.
So they just survived the processing.
The contaminated protein meal was fed to hundreds of thousands of cows. The prion survived the cow's digestive tract, entered its brain, and amplified massively within the cattle population.
And then humans ate the beef.
When humans then consumed the contaminated beef, specifically products containing mechanically recovered meat that might include spinal cord tissue, the prion managed to cross the species barrier.
It is a devastating example of how an economic decision made for agricultural efficiency inadvertently engineered a fatal, untreatable human epidemic.
It all comes back to the fortified city we discussed at the very beginning.
We built an industrial agricultural supply line that inadvertently smuggled the most bizarre, indestructible invader right past all of our defenses, straight to the dinner table.
We truly did.
Well, we have covered a tremendous amount of ground today. We've seen how pathogens relentlessly exploit the specific microscopic gaps in our global infrastructure.
From the macro to the micro.
A smoky kitchen fire damages the microscopic cilia in a child's lung, allowing pneumonia to take hold. A discarded plastic tire in an expanding urban slum collects rainwater, providing a breeding ground for dengue. An agricultural policy change in a rendering plant creates a prion epidemic.
The interconnectedness is profound.
As climate change continues to warm the globe, expanding the geographical range of vectors like the Aedes mosquito into new latitudes, and as antimicrobial resistance steadily blunts the efficacy of our best antibiotic weapons, the public health challenges of the 21st century are mounting.
They are indeed.
The question for you to mull over as you digest this chapter is this: are our global city walls adapting fast enough to fight tomorrow's siege, or are our policies and infrastructures still relying on yesterday's blueprints?
To help consolidate the specific blueprints we covered today, I'm going to run through our rapid single best answer recall prompts. I will read the question, pause for exactly 3 seconds to let you think, and then provide the answer and the specific chapter reference so you can review. Let's begin. Question 1. According to WHO clinical algorithms for resource-poor settings, a child aged 12 to 59 months is diagnosed with non-severe pneumonia based on which respiratory rate threshold? I will pause for 3 seconds.
Take your time to think about it.
Answer: 40 breaths per minute or more. You can review this in this section on acute respiratory infections under Issues in Presentation. Question 2. In developing countries, what is a highly prevalent bacterial cause of early-onset neonatal sepsis, contrasting with Group B Streptococcus in developed nations? 3, 2, 1.
Got your answer.
Answer: Klebsiella pneumonia. Review this in the neonatal sepsis section under Etiology. Question 3. Why was the standard WHO oral rehydration solution modified to a lower osmolarity formula? I'll pause for 3 seconds.
Think back to the cholera discussion.
Answer: to reduce the risk of hypernatremia in children with non-color watery diarrhea by optimizing the sodium-glucose cotransport mechanism. This is covered in the gastrointestinal tract infections section under medical treatment. Question 4. A patient presents with dengue hemorrhagic fever. This severe manifestation is most closely associated with which epidemiological history? 3, 2, 1.
The Trojan horse mechanism.
Answer. Secondary infection with a different dengue virus serotype, leading to antibody-dependent enhancement. Review this in the dengue fever section, under Issues and Presentation. Question 5. What is the most cost-effective public health strategy for reducing the burden of soil-transmitted helminths in children? I will pause for 3 seconds.
Think about the herd effect.
Answer. School-based mass drug administration using anthelmintics like albendazole or mebendazole. This is found in the parasitic infection section under preventive measures.
Yep.
Question 6. On an MRI, the pulvinar sign in the posterior thalami is highly indicative of which prion disease? 3, 2, 1.
Final question.
Answer. Variant Creutzfeldt-Jakob disease, or VCJD. Review the prion section under Diagnosis and Treatment.
Excellent. Thank you all for joining us on this deep dive into infectious disease and public health architecture. Remember, whether you are a medical student, a clinician, or a public health trainee, you are the structural engineers of tomorrow's health systems. Keep your walls strong, your data accurate, and your water clean. We will see you on the next deep dive. Here are the details of this episode.
Infectious diseases. Byline. Transmission dynamics, global inequities, and the evolving landscape of communicable disease control. Episode description. Infectious diseases remain a central pillar of public health practice. Despite advances in vaccination, sanitation, and antimicrobial therapy, communicable diseases continue to shape global mortality patterns, particularly in low- and middle-income countries. This episode examines modes of transmission: airborne, vector-borne, waterborne, contact. This episode examines basic reproductive number and transmission dynamics. This episode examines herd immunity and vaccination coverage. This episode examines antimicrobial resistance as a global threat. This episode examines emerging and re-emerging infections. This episode examines zoonotic spillover and environmental change. This episode examines health system capacity and outbreak response. This episode examines global surveillance networks. This episode examines the intersection between infectious and non-communicable disease. This episode examines infectious diseases reveal the importance of collective protection. No individual exists outside the network of transmission. Sanitation systems, vaccination programs, surveillance infrastructure, and global coordination determine population risk. This episode examines. The episode also explores how antimicrobial resistance threatens to reverse decades of progress, underscoring the need for stewardship and innovation. This episode examines. Infectious disease control depends on science, governance, and trust. This episode examines key takeaways. This episode examines. Infectious diseases remain major contributors to global mortality. This episode examines. Transmission dynamics shape prevention strategy. This episode examines. Vaccination programs reduce morbidity and mortality at scale. This episode examines. Antimicrobial resistance is an escalating global concern. This episode examines. Zoonotic spillover is influenced by environmental change. This episode examines. Surveillance and rapid response systems are critical. This episode examines. The global coordination strengthens outbreak control.